Good morning. Hey, this is Dr. Rutledge, and recently got an email from one of the participants in the Mini-Gastric Bypass 1 Anastomosis Consensus Conference held in Paris. And in Paris, we were pleased to have so many surgeons from around the world with large volume experiences in Mini-Gastric Bypass and 1 Anastomosis Gastric Bypass talking about their good results. And it brought up a variety of important issues. But one of the issues that I recently got an email about is the persistent question about the Billroth II and its association with gastric cancer. Now, I put together a slide presentation on this and a quick summary, I think, that anybody who is considering mini-gastric bypass, 1 anastomosis, or Billroth II for any reason should have in their knowledge base to answer questions, but also to understand what the medical literature shows on this topic. And so I thought I'd go through that a little bit today. And I'm going to key on a particular article, which I think is really amazing because of just how poor the quality of scholarship is in this article. And so this is an article published in the Archives of Surgery. And basically it says, gastric bypass, is a Roux limb necessary? And basically it was asking the question, can we look at the medical literature and determine the need for a Roux limb when you do a gastric bypass? And again, just to restate their objective is to highlight the clinical and experimental rationale to perform a Roux limb for a bariatric gastric bypass. And so that makes a lot of sense. And they said data sources. They reviewed PubMed citations on Roux and why. And they looked at clinical and experimental studies. And they did data extraction and synthesis. And it's interesting, they said no formal data extraction was performed, but they looked at in vivo, live, and experimental models of duodenum and the potential molecular mechanisms to lead to bile causing or promoting gastric cancer. And then this is their conclusion. So, and I think this is a good summary. Recent data suggests that laparoscopic loop gastric bypass performed without creation of a Roux gastroenterostomy is faster and confers similarly excellent weight loss compared to the Roux and Y. But, and this is, I think, their conclusion, which we're going to address today, in the absence of a Roux limb, the long-term effects of chronic alkaline reflux are unknown. Okay? Let me say this again, because this is so obviously wrong from a group of writers who say they reviewed the medical literature, that it's really stunning in its absence of even a moderate amount of intelligence on this topic. So it really catches you by surprise. In the absence of a Roux limb, the long-term effects of chronic alkaline reflux are unknown. One more time. I can't get over this. In the absence of a Roux limb, the long-term effects of chronic alkaline reflux are unknown. And then, so we're going to come back to that statement again. Then they say animal models and in vitro analysis of chronic alkaline reflux suggest it could have a carcinogenic effect. And that's very true, very interesting. And they actually have a little graph there where they showed that in mice, they did a total gastrectomy, an esophagojejunostomy. Esophagojejunostomy, again, very important points here. Esophagojejunostomy, and that those rats in that study had an increase in esophageal cancer, and they have good pictures of that. And so they think that, you should do a Roux and Y. Okay? And so both of these statements are so obviously wrong, it just takes your breath away. So I'm going to come back to an overall discussion of esophageal cancer, the risk of esophageal cancer after both the sleeve and the band, and the risk of gastric cancer after a Billroth II that's performed in the MGB. But let's just focus on these two statements to begin with, and then we're going to give you a lot more background in this presentation this morning. So, again, in the absence of a Roux limb, the long-term effects of chronic alkaline reflux are not known. So what this suggests is the authors here, or whoever wrote this particular sentence of the entire group, because there are multiple authors, and maybe it was just one surgeon in particular who wrote this, but they all are responsible for this. They must have forgotten that the Billroth II type connection's been done for over 100 years. So of any general surgery procedure that we know in the world, of any general surgical procedure done on human beings that we know in the world, we know that in the absence of a root limb, we know the results of chronic alkaline reflux. We know it because hundreds of thousands and probably total over 1 million people have had Billroth IIs regularly for the past 100 plus years. So we absolutely do know the results, and we're going to talk about them. And basically they show that there's very little effect and probably no effect, but we'll go into that in more detail. But this statement is just incredible. And presumably the editors at the Archives of Surgery who reviewed this, the chief editor reviewed this. But I mean, again, let's look at the statement. In the absence of a root limb, the chronic alkaline reflux results are unknown. We've had 100 years of Billroth IIs. As we're going to say, there are over 1,000 papers in the medical literature on Billroth IIs and chronic alkaline reflux from a Billroth II. So to say it's unknown is just stunning to me. And we're going to give you more data on that and give you quick answers on some of these things. But so, and then they say animal models, and particularly the animal model they talk about is an esophagojejunostomy. Again, what we see here is a complete absence of knowledge of general surgery. Even a medical student would realize that a Billroth II is never performed following a total gastrectomy. In other words, Billroth IIs are used in a certain situation, and that situation is following a distal gastrectomy, an antrectomy, a drainage procedure, things like that. So antrectomy in Billroth II is done all the time. As we're going to point out, in the past 3 months, there have been dozens of articles by gastric cancer surgeons using Billroth IIs to reconstruct gastric cancer patients. So it's routinely done by surgeons who are general surgeons who understand general surgery, and this is an example of really poorly informed surgeons who presumably are bariatric surgeons and have forgotten their general surgery or their oncologic surgery or even their medical student training. So there's no question that a Billroth II anastomose to the esophagus should never be done. In fact, the Roux-en-Y was invented in the early 1900s by Cesar Roux as a resection and reconstruction after total or near total gastrectomy. And they recognized even back in the early 1900s that a Billroth II type reconstruction after total gastrectomy or subtotal gastrectomy is never appropriate. And we're going to talk more in detail about this. But then to show their concern and their lack of knowledge, they say, oh, let's look at the danger of an esophagojejunostomy. And again, that's not what a Billroth II should ever be used for. So we're going to go into more detail on this. But this particular article comes up. It's an argument in favor of the Roux-en-Y. And again, it's stunning in its conclusions. The first part of the conclusions are quite correct. That is, the mini-gastric bypass is very effective, easier to perform, it's easier to revise, it's more powerful in general according to more recent data, and we now have 10 and 15-year data suggesting excellent outcomes. And in contrast to forming cancer after Billroth II mini-gastric bypass, we're seeing cancers after sleeve and band surgery, which does cause acid reflux and does cause esophageal cancer. And again, we'll go into more detail. But basically, this morning's talk is based on an email that we got on this particular topic. And I wanted to start off with the kind of inciting event, this article, which was published and really is kind of remarkable because of its lack of insight. And so let's go through some of that now. And the title of this talk is What Happens When General Surgeons Become Bariatric Surgeons and Forget Their General Surgery Training. And I think this article is really a great example of that, or a disappointing example of that. This is surgeons quoting and making statements which show a complete lack of understanding of the medical literature and the history of general surgery. So we're going to talk a little bit about that this morning. And particularly it focuses on fear. In other words, we know that surgeons and their patients are making life and death decisions every day. The assumption would be that when we make these decisions, we make them rationally, that we do careful consideration. Yet, the research on human decision-making is not very encouraging. I'm not sure we'll have enough time in this particular video to talk about this morning, but we're going to talk in some of the other upcoming videos and some of our published papers on cognitive bias. And that is where our wonderful, highly intellectual decision-making processes are derailed by what are called cognitive biases, and how we could possibly get this kind of article, which is a complete absence of insight into general surgery history and the medical literature, will be something we'll talk about. But particularly, we noticed this fear of cancer. We brought up in this article no actual data, no suggestions, no numbers, but just fear of cancer. When you say cancer, it's very scary. And of course, they didn't talk about, for example, what's the death rate of bowel obstruction, how many people after Roux-en-Y will have bowel obstruction, what the long-term risk is. And there's good research to show that different types of fears are graded inappropriately by humans. So, for example, there's good research to show that people have a tremendous and deep fear of the word and the disease of cancer. Things that we're familiar with, like surgeons are familiar with bowel obstruction because they see it and treat it much more frequently, seems to engender less fear. So even though bowel obstruction after Roux-en-Y is relatively common, depending on what article you read, you may see anywhere from 1 to 15% of patients within the first several years may be diagnosed with bowel obstruction after Roux-en-Y, and particularly higher after laparoscopic Roux-en-Y. Yet there's very little fear reported in that complication, even though the death rate compared to a 40-year risk of getting cancer of the stomach is quite low. Just the name, the word cancer, engenders fear and affects our decision making. And if we have time, we'll go into that topic. Okay, let's give a bit of background. The mini-gastric bypass is based on two routinely performed, regular, standard surgical procedures which have, as I mentioned, over 100-year history. The Billroth II has been performed for over 100 years, and as we're going to point out, from looking at the national inpatient sample from the United States, over 16,000 Billroth II procedures were performed in the United States in 2007. The Billroth II reconstruction is routinely performed for trauma, ulcers, and cancer of the stomach. And let me emphasize, we're going to talk about this more, but the Billroth II is routinely used by oncologic specialists as a treatment to reconstruct the stomach after resection for gastric cancer. The Billroth II is used in gastric cancer patients by gastric cancer surgeons routinely. So this article, for example, in Archives of Surgery by Bariatric surgeons show they are frightened. They raise concerns. They raise the fear of gastric cancer, particularly actually esophageal cancer. Yet, those who are most knowledgeable in the area of gastric cancer routinely use the Billroth II for reconstruction. And why would we have that dichotomy? Well, the thesis of my presentation is going to be that surgeons who have become bariatric surgeons have often forgotten some of the basics of general surgery. And so we'll talk a little bit more about that. The mini-gastric bypass itself uses a Billroth II type connection. In my personal series, there's over 6,000 patients now. We've got 15-year follow-up. There's also been controlled, randomized, prospective trials of the mini-gastric bypass compared to the Roux-en-Y with excellent results. Long-term data suggest that the mini-gastric bypass is easily performed, has a low risk, has excellent weight loss, and is very powerful. And it uses two basic general surgery components, a vertical gastric tube or a collis-type gastroplasty, and a gastric bypass with a Billroth II gastrojejunostomy. Again, a standard technique, and in contrast to the erroneous statement in the previous paper, it's very clear what the long-term results of that Billroth II is, and we're going to talk about that. But again, let's emphasize that people are bringing this issue up as a fear of gastric cancer and bile reflux, and this is a comparison in this presentation today is a rational review of the literature versus kind of a more primitive reptilian brain response. When you just hear the word cancer, it sounds scary to people, and they misjudge relative risk and relative importance. So we're going to talk a little bit about that. The other thing that's important to point out is doctors routinely have been shown to not be very good at analyzing and reading the medical literature. Again, probably the The best example I have is this one, where again we have the quote, "In the absence of the roux limb, the long-term effects of chronic alkaline reflux are unknown." The Billroth II has been done, as I said, for over 100 years. There are over 1,400 papers on the Billroth II published, and so we really do know what the chronic alkaline reflux in a Billroth II causes. We know that. These authors did not know that, but it's only because they did not read the medical literature. So let's talk about that. Well, we're going to go over about 6 major points, and we'll go over them in detail, and then we'll go over them in summary, and then we'll even make them into a real short, hopefully a memorable slide so we can put all this in one place. First, it's very important to know that gastric cancer is declining. It's declining rapidly. It's decreased 4-fold in the United States since 1930. Gastric cancer is one of the biggest success stories in the area of oncology and gastric cancer. In the area of cancer. And the reason for this is because of the etiology, the underlying etiology, as we'll talk about, is alcohol, cigarette smoking, and particularly highly processed foods, so that you talk about meats that are stored and cured with smoking or salting, which can cause the development of nitrates, and also a low dietary intake of fruits and vegetables. But as the refrigerator and newer techniques for providing healthy food to societies around the world have advanced, the incidence of gastric cancer is plummeting. And this is going to be, as we'll talk about, in contrast to the rapid rise in esophageal cancer. And we're going to talk about esophageal cancer and its relationship to the lap band and the sleeve, which are truly precancerous surgery. And here we have this particular surgeon talking about the risk of gastric cancer, and never mentions in that article the tremendous decline in gastric cancer, which gives us hints as to the cause and to the prevention of gastric cancer. For example, there are 40 deaths from stomach cancer per 1 million population in the United States in 2009. So 40 cancer deaths of the stomach, 40 out of every 1 million population. So we're talking about a relatively uncommon disease, 40 cases of death. And remarkably, the mean age of these people who died from gastric cancer was 73. So it's a declining illness. It's occurring 40 out of a million. If you're one of those 40, that's obviously terrible. But 40 out of a million population in 2009, it's certainly not on the highest levels. And the people who are succumbing to this illness, as tragic as it is, show that their age, on average, is quite advanced. So that if these individuals were completely cured of their gastric cancer, or the gastric cancer were prevented, they're close to the median age of death of men in America, as it is. So that the total years of life lost by gastric cancer in the United States is relatively small. 2/3 of stomach cancer patients are older than age 65. So it's a disease that is declining rapidly. It's primarily in very aged individuals who would often expire from some other reason if they had not lost their lives due to gastric cancer. The second point, environmental causes of gastric cancer show that it's relatively easy to prevent it, and that's important to know when we start talking about gastric cancer overall. What does cause gastric cancer, what we're going to emphasize, is not a Billroth II. Primary causes are dietary, particularly fried, salted, smoked, and preserved foods. Nitrates, which are converted to carcinogens by bacteria and acid in the stomach, tend to cause or be strongly associated with gastric cancer, and fruits and vegetables protect and tend to inhibit and protect against gastric cancer. Therefore, stomach cancer is much more common in individuals who smoke or have heavy alcohol intake. The other important thing to point out, and which again is not mentioned in this particular article that we're critiquing today, is the new insight that H. pylori is the primary causative agent of gastric cancer. There are many studies which quote that in the absence of H. pylori, there's no gastric cancer. So H. pylori, the infection of the bacteria Helicobacter pylori, is a primary agent in the development of many, if not all, gastric cancer. And that has implications such that if there are concerns about gastric cancer, then we can look at this data. This is point number 2 of the causes of gastric cancer and see it's pretty easy if you're frightened of gastric cancer, which is a reasonable thing to be frightened of. The things that you can do to protect you or your patient from gastric cancer are very simple. Avoid fried foods, salted, smoked, and preserved foods. Don't smoke or drink high amounts of alcohol. Take a diet that's relatively high in fruits and vegetables. And if you want to be very aggressive, you can treat H. pylori. These are very simple things and don't mean you have to suffer through and have a dangerous, difficult to reverse, and high failure rate operation like the Roux-en-Y, the sleeve, or the lap band. Here's a quote of an article from Gastroenterology, published from Taiwan, where they have a relatively high incidence of gastric cancer. And basically, the studies show that H. pylori treatment normalized the risk of gastric cancer in ulcer patients. So let me emphasize that again. Early treatment of H. pylori in gastric ulcer patients decreased the risk of gastric cancer to normal. Okay, let me say it again. You're worried about gastric cancer. Treat H. pylori normalizes the risk of gastric cancer. Okay? If you're worried about gastric cancer, the bacteria Helicobacter pylori is one of the primary underlying causes of gastric cancer, and it's treatable. If you're worried about gastric cancer, the things to do, you don't have to make up stories about the Billroth II. Again, what can you do? You're afraid, you're frightened. You've heard this fear of gastric cancer. And so deep in the primitive parts of your brain, I'm frightened of gastric cancer. That's all right. But the thing to do is to pay attention to those things that really make a difference. And that is to avoid alcohol and tobacco, avoid processed and preserved meats and highly salted foods, treat H. pylori, and eat a diet that's high in fresh fruits and vegetables, and maybe yogurt and green tea have also been shown to be effective. So there's some really straightforward things if you're worried about gastric cancer, and we can decrease the incidence of associated gastric cancer by 2 or 3 or 4-fold with these kinds of simple interventions. Okay, now, there are some studies that do show that patients who have a Billroth II, when followed for 20, 30, and 40 years, can have an increased risk of gastric cancer. And we're going to talk about that. But for point number 3, we'd like to emphasize that there are many large-scale studies of patients who have a Billroth II, followed for 20 years, that have no increased risk of gastric cancer after Billroth II. Okay? So let's talk about an excellent study from the Mayo Clinic. This is a study published, it's important to note, back in 1983. Okay? They looked at 338 Billroth II patients. They followed them for 25 years, a quarter of a century. So they had 5,000 plus years of patient follow-up. In that series, 2 patients in 5,000 years of follow-up developed gastric cancer. Now, that's 2 cancers of the stomach followed for 5,000 years. But importantly, they looked at the risk of gastric cancer for those people who lived in the area around Mayo Clinic in Olmsted County, Minnesota. And they predicted, based on the age, the smoking history, and other things, that these Billroth II patients should have had, during those 5,000 years of follow-up, about 2.5 cancers. That is to say, the risk of gastric cancer in the patients who had Billroth II was lower than the population in Olmsted County, Minnesota, surrounding the Mayo Clinic. Billroth II for ulcer in these patients, long-term, 25 years of follow-up, 5,000 years of follow-up total, had a lower than expected risk of gastric cancer. And remember that the rate of gastric cancer is declining. This was published in 1983, and gastric cancer has declined by 20 to 50% since then. So that means that what we're really talking about is we found 1 cancer predicted, and if it was done today, 1 cancer out of 5,000 patient years, and it's actually lower than the risk in general population. And remember, let's go back to that statement in this particular article. And let me just quote it one more time. In the absence of long-term data, we don't know what the chronic alkaline reflux results are. They're unknown. They are known. The surgeons who wrote this article just didn't know the medical literature. We know exactly, with 5,000 years, 5,000 patient years of follow-up, the risk of gastric cancer is actually lower in these Billroth II patients than in the general population. Just as another example, there's an article by Basile published in the year 2000 in General Gastroenterology and Hepatology. They found no increased risk of gastric cancer after Billroth II. They had 30-year follow-up in 500 patients. And their quote was, "The risk of gastric cancer is not increased after Billroth II." Remember our article? They said they don't know. It's unknown to those authors. It's unknown to those authors because they didn't actually read the medical literature. They've forgotten their general surgery, is my premise. Because if they read the medical literature, they would know that we have 100 years of experience with the Billroth II, and there are some studies, which we're going to come to in a minute, that show a slight increase in risk, but there are many studies that show no increased risk. And those studies were performed and reported up to 10 and 20 years ago. And since that time, there's been a tremendous decrease in gastric cancer, and we understand more about the underlying causes, including brand new information on the fact that Helicobacter pylori treatment could potentially eliminate all gastric cancer. Now, the next point we want to emphasize is to point out that there are some studies that show there is a small increased risk of gastric cancer after Billroth II. So, for example, recently I was in England, I gave a presentation, and an oncologic surgeon in the audience raised his hand and said, "I just saw a stump cancer. A patient had a Billroth II 35 years ago and had a gastric cancer." And so, this is obviously a tragedy for that patient, and it brings up the whole issue. That Billroth II patient sustained a gastric cancer. This is what we're frightened of. And so let's look at this. There are some studies that show an association with gastric cancer and Billroth II. But we want to emphasize that, again, sometimes surgeons lack understanding of the medical literature and of science in general. So, for example, does association prove causation? And is there a difference between association and causation? We recently did a survey of over 100 bariatric surgeons from around the world, and what we found is those surgeons who fear gastric cancer often erroneously mix association and causation. And so let's talk about that. Again, there are some studies that show a slight increased risk of gastric cancer after Billroth II. There are some studies that show a slight increase in risk of gastric cancer after Billroth II. But this is very important. In these studies, those patients who had the Billroth II for a reason. Okay? The vast majority of those patients undergoing an operation which included a reconstruction with a Billroth II gastrojejunostomy had it as a primary treatment for ulcer disease. Okay? Now let me say this again because this should be obvious of where I'm going in this presentation. Again, there are studies which show an increased risk of gastric cancer after Billroth II. Okay? But let us take a moment and think, why did those patients have a Billroth II? They had a Billroth II because they had underlying ulcer disease. Now, what do we know about the etiology of both gastric cancer and ulcer disease? They have a common underlying etiology. That is, both are caused in large part by infection with Helicobacter pylori. If you had a disease, which is an infection with Helicobacter pylori, and then you got a Billroth II, would it be surprising that 20, 30, or 40 years later, you had another disease that's caused by Helicobacter pylori? I think not. What we're pointing out is that Billroth II may not be causative of that increased risk compared to the general population. It may, in fact, be the underlying ulcer disease and the underlying infection with Helicobacter pylori. It also brings up the issue that if you wanted to intervene with this particular population, it might be easily done by changing the diet, avoiding smoking and alcohol, and particularly treating the underlying infection with Helicobacter pylori. There have been a meta-analysis, which I think was pretty good. It was 12 studies, and the relationship with Billroth II and gastric cancer was small. That is that they found that in the meta-analysis of 12 studies, there were 7 studies, just a little over half, that showed a small increase in risk of gastric cancer after Billroth II. But there were 5 studies showing no increase in risk. And again, this association can be confusing. If you just read it that far, you're okay. But if then you say, aha, Billroth II can cause gastric cancer, as is said in this article. As is said in this article, we don't know what's going to happen. We actually do know what's going to happen. We know that there is a slight increase in risk in some studies, but we understand that that association may have more to do with the reason the Billroth II was done as opposed to the Billroth II itself. The Billroth II surgery in those patients was done to treat ulcers, and ulcers increase the risk of gastric cancer. Ulcers and gastric cancer have a common underlying etiology. So, for example, a study of 3,000 gastric cancer patients versus 89,000 controls showed ulcer increased the risk of gastric cancer by about 1.5 times. That's about the rate that we see in those articles that look at the increased risk with Billroth II. And there are many other studies that confirm these findings, but basically ulcers increase the risk of gastric cancer. Ulcers are associated with an increased risk of gastric cancer. Ulcers have an underlying etiology that's the same as gastric cancer, which is Helicobacter pylori. Therefore, the Billroth II may have little or no effect other than being associated with the treatment of ulcer disease. Another important point is to look at the difference between statistical significance and clinical relevance. Okay? Something can be statistically significant, but not clinically relevant. So, what we're going to talk about here is to look at the magnitude of some of these issues. Okay? So, the next point we want to talk about is, we classify this in my list of 6 points as point number 5, and that is, the Billroth II has been done on hundreds of thousands of patients as a treatment for underlying ulcer disease, for trauma reconstruction, and for the treatment of gastric cancer. What is the general advice for those patients? What do gastroenterologists recommend for patients with the Billroth II? Okay? In other words, if as this article, and again, say, in the absence of a roux limb, the long-term effects of chronic alkaline reflux are unknown, and animal models and in vitro analysis of chronic alkaline suggest a carcinogenic effect. If all these people are dealing with this carcinogenic Billroth II, what do the gastroenterologists, what do our internist colleagues recommend for long-term monitoring of Billroth II patients? Should they have like endoscopy every 5 years, every 10 years, every 20 years? Well, the answer is that many studies on this topic have been performed. And other than endemic areas like Japan, follow-up of in one study published in 1983 in the British Journal of Surgery, they followed 1,000 Billroth II patients with 22 to 30-year follow-up. Endoscopic screening, according to their analysis, showed no cancer, and they are quoted as saying that endoscopic screening is unrewarding. And remember, this is published in 1983, and since that time, gastric cancer is declining precipitously. So in 1983, it said it was not worthwhile to do endoscopy. When I was in England, a surgeon said, well, he recommended, and he was going to do follow-up and do endoscopy screening on his Billroth II patients. Well, there's nothing wrong with that. But he might as well do endoscopic screening for gastric cancer on the general population. In other words, bring everyone in at 5 or 10 or 20 years and endoscope everybody looking for gastric cancer, because the incidence is going to be about the same, and thousands of people will have to be endoscoped to find one gastric cancer. Much more valuable would be to say, don't smoke and eat a healthy diet and avoid processed, salted, and preserved meats. So they're really simple things, and if you want to be very aggressive, you could treat H. pylori or diagnose and treat H. pylori. But screening endoscopy is not recommended. Screening endoscopy routinely for Billroth II patients is not recommended. It's, quote, unrewarding, and that was in 1983 when the rate of gastric cancer was 2 to 4 times higher, depending on where the study's done. Since that time, gastric cancer is precipitously declining because the underlying causes of gastric cancer are clear, they're easy to recognize, and easy to use to prevent gastric cancer. So routine follow-up is not recommended for Billroth II patients. So what we like to say as a simple quote is that bariatric surgeons fear the Billroth II and gastroenterologists ignore it. Hundreds of thousands of people with Billroth II. We know that gastroenterologists are very willing to endoscope people for follow-up. For example, Barrett's esophagus and reflux esophagitis. Aggressive follow-up is routine. Yet, the risk of Billroth II associated gastric cancer is low. Finally, number 6. Bariatric surgeons fear the Billroth II, but cancer surgeons, general surgeons, use the Billroth II. As I mentioned earlier, if you just do a search on Billroth II in PubMed, you find over 1,400 articles on the Billroth II. Okay? So again, we quote this article. It said in the absence of a roux limb, the long-term effects of chronic alkaline reflux are unknown. So these 1,400 articles, I guess, were missed by these authors. Let's point out that general, trauma, and particularly cancer surgeons, oncologic surgeons, gastric cancer specialists routinely use the Billroth II. As we pointed out earlier, in review of the national inpatient sample in 2007, over 16,000 patients had a Billroth II in the United States. While bariatric surgeons, and as an example of it is shown in this article, fear the Billroth II, general surgeons use the Billroth II routinely in their practice. We'll give you a couple of examples. Korea, it's worth noting, has the highest risk of gastric cancer in the world. In April 2012, there are 2 papers by oncologic specialists from Korea and China, 370 cases in the 2 articles, and both presented the results of antrectomy and Billroth II as a treatment for gastric cancer. Okay, let's just stop for a second. These are patients with gastric cancer. Patients with gastric cancer were treated with a Billroth II reconstruction, okay, by oncologic specialists in some of the areas of the earth that have the greatest incidence of gastric cancer. Okay, if gastric cancer is terrible and frightening, and the Billroth II has any association with it at all, would these oncologic specialists, knowledgeable specialists who are publishing in the area of gastric cancer and gastric cancer surgery, would they be using a Billroth II? Bariatric surgeons, as exemplified in this article, fear the Billroth II. General surgeons who have adequately reviewed the medical literature use the Billroth II routinely. In the first 3 months of 2012, there are 20 other similar papers in which Billroth II reconstructions were used in gastric cancer patients. The Billroth II is reasonable and acceptable. It's not perfect, but it's a very good and routinely used operation. But most importantly, this article is an example of really poor scholarship. Particularly, I like to emphasize the Journal of Korean Surgery, where they have a very nice demonstration of the Billroth II reconstruction after resection of the antrum for gastric cancer. And if you look at the figures of the actual surgery being performed, you can see it's essentially equivalent to a mini-gastric bypass. So this is an oncologic surgeon choosing to perform the equivalent of a mini-gastric bypass. Okay, let's emphasize our talk again. Uninformed surgeons fear the Billroth II, general surgeons use the Billroth II. A Billroth II gastric jejunostomy is common, accepted reconstruction after enterectomy. A Billroth II is not, should never be used as a reconstruction following total or subtotal gastrectomy. Again, this is an area of confusion. People remember the old Mason loop. Okay? Billroth II is fine for the distal gastric reconstruction. It should never be used as a reconstruction after a total or a subtotal gastrectomy. And again, that's just basic general surgery. We shouldn't have to be telling our bariatric surgery colleagues this kind of information. This is just basic general surgery, and the fact that they don't understand this is really, I think, kind of embarrassing. A Billroth II with an anastomosis at the junction of the body and the antrum of the stomach, such as in the mini-gastric bypass, is reasonable and acceptable surgical choice. The old Mason loop gastric bypass placed the Billroth II high on the stomach, adjacent to the esophagus, and that's never acceptable. No medical student, no general surgery resident, no general surgeon would pass their boards or tests if they said that they should reconstruct a total gastrectomy with an esophagojejunostomy as a Billroth II loop. It's just not an appropriate reconstruction. And we know that for 100 years. It's not new information. Mason made that mistake, and he disavowed it very quickly, actually. He went on to advocate the vertical banded gastroplasty. But it's not reasonable. And again, many of the critics of the mini-gastric bypass kind of fail to understand this. Again, it's a subtlety which escapes them. And again, that's why it's worthwhile kind of reviewing this data carefully. Okay, let's summarize again. I'm going to go through 6 points. And again, the topic is uninformed surgeons fear the Billroth II, educated surgeons use the Billroth II. 1, gastric cancer is declining rapidly, over 50% recently. 2, gastric cancer cause and prevention. You need to know this if you're worried about gastric cancer. And the causes and the environmental factors are easily prevented. Diet, lifestyle changes, and treatment of H. pylori. Avoid alcohol and smoking, processed salted meats and foods, and seek a diet that's high in fresh fruits and vegetables. And you can decrease the incidence of gastric cancer well below the general population. Number 3, many large-scale studies show no increased risk. I mean, there are many large-scale studies show no increase in risk. There's many studies show no increase in risk. There are some studies showing the Billroth II does associate with an increased risk of gastric cancer. But it's small, and most of those patients had a Billroth II for ulcer disease, suggesting that the association of ulcers and gastric cancer is the primary etiology, not the Billroth II. Okay, number 6. Endoscopic screening of Billroth II is not recommended. Why? Because the risk is so low. You might as well go out and screen the general population with routine endoscopy looking for gastric cancer. And then number 6, general, trauma, and particularly oncologic surgeons routinely use the Billroth II. Uninformed surgeons fear the Billroth II. Educated surgeons use the Billroth II. The Billroth II and the mini-gastric bypass are excellent, safe, and effective surgeries. If you fear gastric cancer, there are things you can do. Avoid alcohol, tobacco, processed and preserved meats, treat H. pylori, eat fruits and vegetables, and maybe yogurt and green tea may also be valuable. But the Billroth II, presence or absence, probably makes no difference at all. Again, 6 points. Let's do it again. Rational data analysis versus irrational fears of gastric cancer. Number 1, gastric cancer is declining rapidly. Number 2, gastric cancer primarily environmentally caused, easy interventions to prevent it. 3, many large-scale studies show no increase in risk. 4, some studies show a small increase in risk, but remember that these Billroth II patients had their Billroth II primarily for ulcer disease, and ulcers and cancer have the same underlying etiology, H. pylori. Number 5, endoscopic screening is not recommended because the risk is so low. Finally, 6, general and trauma surgeons, and particularly oncologic surgeons, routinely use a Billroth II reconstruction. If you fear gastric cancer, there's things you can do. But a Billroth II probably makes no difference. If you're frightened of gastric cancer, there's ways to avoid it. You should learn about it before you make a decision, but a Billroth II probably makes no difference. We'll do another video later talking about what you should fear, which is esophageal cancer after the sleeve and the band, and we'll talk about that later. But for now, let me thank you for listening. And there's a slide presentation of this available under my name, Dr. Rutledge, at slideshare.com, slideshare.net. So don't hesitate to contact me if I can provide you with any further information. Thanks very much.